everyone. Okay, I think we're going to get started even as people continue to join us. So welcome everyone. I'm Thea de Gruchy. I'm a postdoc at the African Center for Migration and Society at WITS. I'm very excited to be the host of the third Pandemic Pangolins webinar, Human Rights and Fighting Discrimination During Epidemics. Today's presenters are two incredible women who've worked hard within their various capacities to improve the access that marginalized communities and populations have to healthcare. Dr. Tialeng Mofokeng is the United Nations Special Rapporteur on the Right to Health, a Commissioner for Gender Equality, medical doctor, women's rights and sexual and reproductive health rights activist, and author of the popular book, Dr. T, A Guide to Sexual Health and Pleasure. And Professor Jo Veary is an associate professor and director of the African Center for Migration and Society at WITS, where she works on migration and health and the governance thereof. Over the last 6 months, Jo has convened the Migration and Coronavirus in Southern Africa group, MICOSA, a group of 150 activists, researchers, government officials, civil society organizations, and UN agencies concerned with the exclusion of migrant and mobile populations from state responses to COVID-19. So welcome both Dr. T and Jo. We'll start by giving our presenters, Dr. T and then Jo, 10 minutes for a brief input on the topic, reflecting specifically on the question of how we move forward. How do we ensure that human rights, of which the right to health for all is integral, are central in our responses to the longer term damage done by the pandemic and in future pandemic preparedness and disaster management? We'll then open up for questions and what I hope will be a robust discussion. We've put together some questions of our own that we hope will sort of guide that discussion, and I'll share those with you on a slide after the two inputs. But please do start sending your questions or comments through the question and answer function on Zoom. So let's get started. Dr. T.
Hi Thea, how are you?
Good.
I'm good, thanks, and thank you. And good afternoon to all the panelists and all the attendees. It's really great to join you this afternoon for this very important discussion on human rights and using human rights standards as we rethink and refocus all our efforts in terms of the right to health. And just to recap for everyone, the United Nations is one of the international human rights bodies and institutions which works in many countries around the world and has other bodies such as the WHO, UNFPA, UNAIDS, we know of UNESCO, that also do programmatic interventions. And my role currently at the United Nations is one of being an independent expert, and it's called the Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. And it's important to talk about this mandate at this time of COVID-19, because we know that the right of everyone to the enjoyment of the highest attainable standard of physical and mental health is related to many other human rights. It's indivisible, it's non-negotiable, and in fact, there are so many other structural drivers and health determinants that relate to this right, but are not directly, within my mandate. And therefore, it's important to collaborate and again, be present in these types of forums and virtual discussions and meetings to advance and to learn and to share, with each other how to then ensure that the right to health is realized, but also support colleagues who are working to ensure that other rights are also realized. So the right to dignity, the right to information, freedom and security of the person, the right to equality and non-discrimination, the right to bodily autonomy, and we can even talk about, you know, issues around right to water and sanitation, are important, you know, for this mandate, are important for me. And COVID-19 has really shown us that even as a global community, we were never really prepared, and we were never plugged in enough and constantly enough, talking about health planning and resourcing and what that can look like for us to be prepared for pandemics, but also for the day-to-day needs of communities. And some of the challenges that have been emerging around COVID-19 particularly is the issue of availability, accessibility, acceptability, and quality of healthcare. And we know that there are many institutions and especially in communities around the world which work around the defense of human rights and the protection of human rights. But in the pandemic, even those institutions that communities usually depend on for recourse of accountability, their own efforts were also hampered because of travel restrictions and all of the other health considerations that needed to happen. So another challenge, I think, for me in terms of COVID-19 specifically, and in terms of the restrictions, is that accountability is something that has been lacking, and it has required governments and people who are leaders to be even more transparent and to be more intentional about being transparent and sharing information, because other methods that the communities and citizens have to ensure that they are held accountable, unfortunately, a bit slower than usual, and in some communities have ceased to exist. In terms of the right to health, accessing health information is key. And I know in South Africa, there was a lot in terms of public awareness, but that also still only focused on hygiene, right? Wash your hands regularly with water. But no one asked the question, what does the communities in Kwakwa do when they haven't had water for more than 5 years? When the water that comes out of the tap is not even good to drink or even cook with. So when public awareness campaigns are there around hygiene, we need to think further than just churning out information to the public and start to think, but what does this literally mean for communities in Limpopo who also haven't had water for many, many years? And in terms of essential services, some of the challenges that we encountered as clinicians and as people who are present in social media is that some clinics and some community organizations didn't list sexual and reproductive health services as part of their essential services. And so we had to intervene in some instances to make sure that the clinics and the district health understand the importance of including sexual and reproductive health as part of essential services. And I think for me, it speaks to a historical view and positioning often, that as someone who works in the reproductive health space, the needs of women, people who need contraception, people who need safe abortion, the issue of access to condoms and internal condoms, which used to be called female condoms, these issues are often seen as a burden, or as women and LGBT people asking for extra favors from the system. They are still not understood properly within a human rights framework, and the fallout from having public spaces that we can't access condoms, where contraceptives are continuing to be in stockouts even before COVID, where method mixing and interruption was something that many people were used to, unfortunately. It means that even post-COVID, unless we are intentional about challenging these ideas and these views that are so systemic in the public system, we may find ourselves actually just replicating all of these bad habits even after COVID. And for me, I think what's really important is to start to talk about, beyond just the biology of COVID and the disease process, even just access to medical services. We know it's a problem, but we need to talk about social structures in society. We need to reimagine what a strengthened community system looks like, and invest and resource those people who are leading in communities and doing the work, and talk about the speed of scientific advancement, but let's talk about the bioethics of biomedical advancements and technologies. It's very important, especially when you're talking about health equity. Everyone is now talking about the people's vaccine, the fact that COVID-19 cannot again fall into the hands of capitalism, where it's only the rich countries who can even put, endowments in the hundreds and billions of US dollars to secure production and procurement of the vaccine, when the global south and more developing countries and more poorer countries are then left out and shut out. So there's a lot in terms of using human rights as a standard, but also using human rights frameworks for accountability. And I think all over the world, whether it's Latin America, Africa, Asia, North America, even in Europe, the issue of accountability is a big one. And it's a big lesson that we need to learn from COVID. And unfortunately, we haven't learned much from the HIV. And what COVID is showing us is the tough environment that many communities were already navigating on a daily basis. The difference with COVID is that it's bringing to the fore and it's affecting even people who previously had class protections or locality or their geography being in the USA, right, offered some protection from some of these really bad epidemics and pandemics. If you think about Ebola, how come we never learned from Ebola as a global community? It's because Ebola was affecting West African countries, and it was a disease that seemed to be of poor countries, Black communities, and the global community did not see themselves as potentially being impacted. Whereas COVID is that pandemic that's literally forcing the entire globe to pause and think about, the responses to it. And I think it's very important that as we reimagine, we need to start with what it will take, for the most of us who are vulnerable to thrive, and then build healthier communities and societies using human rights standards as we rethink policy, as we rethink strategies and programs, and also the issue of accountability is key. Thank you.
Thanks, Dr. T. I think that was a really great sort of start to today's session. And I think that a lot of the things that you raised are really important and will serve to sort of outline our conversation going forward, especially that question of accountability and how do we have human rights frameworks and frameworks in which human rights is central for accountability that work during a pandemic and during a crisis and that are accessible at that time. But now we're going to hand over to Jo for her input before we open for discussion.
Hi everyone. Thanks very much, Dr. T, Thea, and the lovely Pangolins organising group. So what I want to do is use my sort of 8-10 minutes to think through some of the ways in which a particular group face specific challenges within the context of epidemics and pandemic preparedness. And it's a group of individuals, people on the move, and here I'm going to focus specifically on individuals who do not hold a South African citizenship. So people who have moved from other countries, including people who will have moved in search of work, in search of employment, education, as well as people who have been forced to flee and are seeking asylum in South Africa. I'm not including in this conversation a particular focus on South Africans who have moved within the country. However, I do want to flag that internal migration, we know that there's far more people moving within countries than across borders. And in our region in particular, this is something key that we need to think about. And what I want to do through that is just alert and remind ourselves that when we're talking about human rights, fighting discrimination, we often talk about particular groups in relationship to others. In our context, I think it's really important to recognize that generally we're starting from a sort of very low baseline, where individuals who are reliant on public healthcare systems within South Africa and the region are facing a multitude of challenges in terms of access, in terms of accessing, as Dr. T mentioned, availability, acceptability, affordability, challenges around accountability. And this is experienced by everyone regardless of citizenship status. we know then that there are additional and specific challenges that particular groups face. So as mentioned, I'm going to talk about people who have moved from other countries. I think the first key issue when we're thinking about rights is that we know that migrant groups are left out of preparedness planning. A global scoping review was undertaken about 1.5 years ago, and that clearly indicated that globally pandemic preparedness plans do not include people on the move or think about migration as a process. And we know that this is particularly ironic given that pandemics, by definition, are about communicable diseases. It's about the spread of disease, which we know is about the ways in which humans interact, including human mobility. And so recognizing that we have systems where they are in place or where a plan does exist that thinks only of citizens is incredibly short-sighted. And I think particularly in a region like Southern Africa, where the legacy history of migration and mobility is so ever present, it's another reminder of how these particular groups get left behind. I think that linked then to that is, what do these limitations then mean? I mean, I would argue that it's not only thinking about discrimination and the rights of individuals who get left behind and looking at what that means from an individual health outcome level, but what does this mean when we think about public health more broadly? A pandemic preparedness plan isn't going to resolve issues at a population level if we leave particular groups behind. So there is this issue of recognizing that in this case, citizens are also facing a range of discriminations and challenges during epidemics due to having others within their community left out of pandemic preparedness planning. I think that, so the language of looking at already marginalized groups and what this then means when we think about groups who face further marginalization is really key. The second key point that I think links to the way in which pandemic preparedness plans are developed is linked to recognizing that we are living in a world where structural determinants of health and the way in which good health outcomes are distributed, so equity in health, are increasingly taking place within a nationalistic, xenophobic, racist society, and the ways in which those political and social determinants of health play out in the ways that they influence policy making and the ways that they influence financing and the ways they influence the delivery of certain programs. And until we're explicitly calling out these forms of discrimination, my fear, and I think this was raised by Dr. T, is very much that these issues aren't going to be addressed. How do we make sure that where we're seeing issues that are explicitly around racism and so forth, that they are being called out and aren't being hidden through the lens of arguing that healthcare systems are simply struggling and that this is the result of a struggling